Hello and welcome to Mississippi Insight. I'm Byron Brown. Thank you for joining us. This week, landmark legislation is working its way through Mississippi's legislature. How are Democratic lawmakers navigating the flow of majority Republican policies? House Minority Leader Robert Johnson III joins us to talk about sweeping tax challenges and changes, medical marijuana legislation, critical race theory, and much more. And on the health front, got sniffles, scratchy throat, 'tis the season for respiratory illnesses, and COVID-19 is far from the only culprit. Infectious disease researcher Dr. Branche walks us through the challenges of diagnosing flu, COVID, even the common cold when their symptoms are so similar. That's coming up now on Mississippi Insight. We are in the midst of a very active legislative session and season, and one of the politicians at the center of it joins me now by Zoom, Robert Johnson III. He is the Democratic representative for District 94, serving people in Adams, Franklin, and Jefferson counties, and the House Minority Leader. Robert Johnson, welcome back to Mississippi Insight.
Well, thank you for having me, Byron.
I want to get your thoughts on something that happened Friday in the Senate. Many of your fellow Democrats there walked out as the chamber, as they took up a bill to ban critical race theory in Mississippi schools. The Republican-led measure passed, and it's headed now to your chamber. What are your thoughts on this bill and the Republicans' overall take on critical race theory?
Well, I've been reticent to talk about that issue at all because it's not an issue. It is a self-created, perpetuated issue, and an answer to a problem that doesn't exist. We don't teach critical race theory. There is no mechanism to have it taught in secondary schools. There's no mechanism to have it taught in college. It is a legal theory that's taught in a limited number of law schools, and it's a self-perpetuated problem that apparently Republicans have come up with, and they're spreading it all around the country. And so, the problem is, and what we're afraid of, is that what people characterize as critical race theory that nobody teaches will turn into keeping people from actually teaching real history. We're not that far removed from having a complete history being taught about this country and about this state, especially about this state. And so now we're afraid that people will want to limit the ability for people to talk about history and social issues in a frank and honest manner.
Well, the House has passed a sweeping tax reform measure. Speaker Philip Gunn was the principal author of it. The bill would lower grocery taxes and the cost of car tags and eventually eliminate the state income tax. This is a measure that you and some other Democrats supported. Why did you get behind this?
Well, as I said last year, and I continue to say that this is a work in progress. The progress has been made compared to the one that we passed last spring. This is a better bill. It has more balance. It creates more benefits for working people. One of the reasons we could find a way to be behind it is one thing. The primary thing is that it eliminated grocery tax. Now it reduces the grocery tax, cuts it almost in half. It reduces the price on your car tag 50%. But more importantly, working people, and I represent, and a lot of us represent a lot of working poor people who have state income tax taken out of their check on the front end. Now they'll have more money to bring home. And so we think that's a benefit for working people. We think that's something that they can take advantage of that'll work for them. And this is all about trying to do what we can to help people who work every day and trying to find a way to have a better life. And so we looked at that. The other issue that we saw, there are a lot of businesses and industry that have been getting tax breaks for years that some of them don't need. They were just having it as like a gift. And so those tax benefits, those tax cuts, those tax abatements that they've been enjoying for years, that's money the state ought to be collecting. And businesses and corporations that are doing very well are in a better position to pay that tax than working people in terms of their income tax. So we like the idea that instead of having tax cuts for rich corporations and rich businesses, that you found a way to give a tax cut to working poor people and working people for that matter.
Are you confident that these tax changes won't leave the state strapped for cash in the years to come, and that we can maintain state services across the board?
We've been assured that we can maintain this. We've talked to the tax experts. We've talked to the Department of Revenue. We may not enjoy the surplus that we have now, but based on the numbers that I see, we'll still have a surplus after these tax cuts. Maybe it won't be $1 billion, but we'll still have a surplus. And all of the forecasts indicate that we'll be able to, that this will be a zero-sum game, that the state won't lose money, and we'll be able to maintain our level of revenue and keep programs working in the state going forward. But I do have assurances from the leadership that we'll continue to monitor it and make sure that the forecast and the research that has been done will be backed up by the revenue collections as we go forward. We'll continue to monitor it and look at it and make sure we're in good shape.
Let's look at medical marijuana. Your chamber added some amendments to the bill that came out of the Senate. Could you kind of recap those changes for us?
So one of the issues going forward, the governor wanted it cut in half, like 1.75 grams. He wanted to make sure that we had enforcement rules in there, that it was that the public is protected. So we didn't reduce it to 1.775. We reduced it from 3.5 to 3, which amounts to about 0.8 grams, or 0.8 ounces, or I'm sorry, 1/8 of an ounce. That's what it will amount to in terms of the dosage. We also allow that, to the extent that you're a producer or a cultivator in the House, in the Senate, it was only zoned in industrial or agricultural areas. We opened it to commercial areas. The idea was that if we're going to do this, we want to make it in terms of encouraging people who have an opportunity to start a small business. We want to make it as flexible as possible, and we did that. And the third thing was we removed the agricultural commissioner out of the bill, out of the law. He was charged with enforcing the rules and the laws that apply to medical marijuana. He didn't, he started out initially not wanting to be in there. He was very adamant that he didn't want to be involved in the program. The Senate left him in there anyway, but it was our feeling if the agricultural commissioner does not want to be involved, we should take him out. And so all of the enforcement and administering will be run through the Department of Health.
We'll have more with Robert Johnson when Mississippi Insight continues. On top of all these things, it's a redistricting year, and there's a plan working its way through the legislature that would essentially put the whole of western Mississippi into Benny Thompson's second district. What's your thoughts on this plan?
I think it's a grossly unfair district drawn for one person. Geographically, it'll have a district that's about 300 miles long. It will be comprised of 40 counties. We only have 82 counties in the state, so almost half the counties will be in the second district. And my thinking about that is it makes it extremely difficult for anybody to get elected, or it'll be very expensive to run in that district. But the other thing is, especially if you're a congressman like Congressman Thompson, who makes it his business to actually touch every county in his district, to try to meet with people in his district, all over his district, which is good governing. It is a good way to make sure that you're attending to the needs of your district. But when you increase the district to that level and that amount, it makes it almost impossible. And I think a fairer plan would be to give him a requisite amount of Hinds County, which would be all of Hinds County, because it's a compact urban area, and parts of southern Madison County, which is these places are places, Hinds County lost population, Madison County gained population, but it's a way to give a person a more compact district. One of the things that the statute requires us to do is make sure that when you draw a district that is compact and you include communities of interest. That district, the third district, the way it was set up, and the second district, the way it was originally set up, which would have included more of Hinds County, makes a more compact district. The district is already huge, large, but putting 4 more counties in it, 4 more counties that actually lost population. So you're not really helping him by doing that. Instead of putting his home county, Hinds County, in a more central area, it makes it better for not just for Congressman Thompson, but for anybody after Congressman Thompson that will be interested in being a good congressman for that district and being effective. It gives them an opportunity to be in a district that's compact and that actually follows the statute and the statutory requirements. And so that's what I think we should do. And that's what our amendment did, and that's what we offered. And so we hope as it goes through this process, we'll continue to work on that district, and maybe we can come to an agreement that makes more sense.
What else would you like to see accomplished in this session from your representatives of the Democratic working with the Republican supermajority?
It's interesting you say that. I mean, we don't have a reputation of working with each other, but the pandemic has forced us to get in a room with some distance and find ways to address the problems and the issues that our citizens are faced with. And one of the major thing is healthcare. Our hospitals and our healthcare community are facing a very critical issue. A lack of staff. I've talked to some people in hospital administration. I think they've lost close to 3,000 nurses. And some people think, they talk about it, and, the speakers talk about, let's do what we can to give hazard pay and enhanced pay. And we need to do that. But we need to address the idea that these people are working in extremely stressful conditions because they're overworked. The hospitals and medical centers and doctors' offices are understaffed. And I mean, we have the lowest per capita patient-doctor ratio in the country. We need to have more doctors. We need to attract more doctors. We have to put money into our healthcare field. So that 1.8 billion some of it will go to do some of that. But we really are beginning to have more discussions with Republicans about Medicaid expansion. We have to do something to put money into the healthcare economy to make sure that we attract more healthcare professionals and do all we can to keep our hospitals open. I had a very good friend of mine passed away last week. He was an older gentleman, but he contracted pneumonia. And normally in a small town like Natchez, they airlift that person immediately to a University Medical Center or some larger medical center. But we couldn't do that this time because they don't have any room. They were full. They couldn't take it. And that is all born out of us not expanding our healthcare outreach through expansion or whatever you want to call it. But we could have addressed all those issues a couple of years ago or last year. But we certainly can't go another year without addressing that because small communities, it's bad enough in urban areas like Jackson, but it is extremely difficult in rural areas where people need more help. And if they can't get help in their rural communities, they at least ought to be able to take advantage of being transferred to a larger community. And now we're in a situation where even in our trauma centers like University Medical Center, Northeast Mississippi Medical Center, larger areas, they can't even take extra patients because they're overloaded right now. So that's what I hope people will, we're all on the same page and understand it's a crisis. We need to get together and figure out how to address it. And so that's what I hope we find a way to work together on.
All right, Representative Robert Johnson, thank you for joining us.
Thank you for having me, Byron, and please welcome me back because we got a lot to talk about and we have a lot to do, and this is a good forum for people to understand what our issues are. And I would encourage everybody to contact your representative, tell them what your problems are, and tell them that's what we want to address, and people need to work together to get that done. Forget party affiliation. What do people need? And that's what we need to address. Thank you for having me.
All right, thank you, and we'll be right back. This time of year, with constant weather changes and any number of airborne infection risks, you or someone you know may be suffering a variety of symptoms: stuffy nose, scratchy throat, maybe aches and fever, maybe something much worse. All these things could be due to anything from COVID-19 to the common cold, but you have to know what ails you before you can treat it. Joining me now to talk about respiratory illness, the flu, common COVID, and much more is Dr. Angela Branche. She is an associate professor of medicine at the University of Rochester in New York State. Dr. Branche, welcome to Mississippi Insight.
Thank you.
Well, flu season is upon us. It likely won't peak until sometime next month, but what are you seeing in the data on the flu in America as we kick off 2022?
So it's been a really interesting flu season. Certainly, it's not like a normal flu season as we know it from pre-pandemic times, but it is also not like what we saw last year. So as you're maybe aware, when the COVID-19 pandemic really started to cause disease and we were seeing an increased number of cases here in the United States in the winter of 2020, so February, March, so forth, that was the tail end of that flu season. And so flu went away. And then in 2020, 2021, interestingly enough, we were in the middle of a huge surge of cases here in the United States. And so we didn't really see any flu that winter, which was unusual and not something that I think most scientists would have predicted. So we weren't able to see any cases. We also didn't see any hospitalizations or any deaths. So it's almost like there was no flu or flu didn't circulate that winter. This winter season, we're starting to see sort of a more pre-pandemic pattern of influenza cases and transmission here in the United States, both down south where you are, as well as up north here in New York. Flu started to really be seen in communities around the end of November. Cases started to rise throughout December and peaked somewhere around Christmas or the week after Christmas. And now what we're starting to see is a gradual decline in the number of cases. So it's a typical season in that you have cases starting in November, peaking around Christmas, early January, and then starting to decline through the end of January and into February. But what's different is that we're seeing about a third the number of cases that we typically might see in a normal winter flu season. And so I think some of the things that already are in place because of the COVID-19 pandemic, things like folks wearing masks when they leave their homes, and sheltering in place, working from home when they can, isolating when they have respiratory symptoms. All of these things are helping to not just hopefully decrease transmission and help us move past the current COVID-19 surge, but also decrease transmission in cases of influenza in communities across the United States.
Now, on top of flu season, we face the common cold. There's another viral illness called the RSV, and of course the COVID-19 Omicron variant. Talk about the challenge for patients and doctors alike to pinpoint the right illness to treat.
Yeah, so, I think something that people maybe aren't fully aware of is that in any winter season, it's not just one virus. It's not just SARS coronavirus 2 that causes COVID-19 or flu. And even, when there's not a pandemic going, it's not just flu. Flu circulates around the same time as other respiratory viruses like RSV or respiratory syncytial virus, which causes pretty severe bronchitis in young kids and also causes pretty bad bronchitis and pneumonia in older adults. And then there's human metapneumovirus. There's other coronaviruses. There's other viruses that cause the common cold. So in any given winter season, all of these viruses may co-circulate around the same time. And so it's always challenging as doctors to know exactly what's causing our patients to become ill. The questions that we are asking now during the pandemic are the questions we always ask in the winter. How sick are you? Do you have a fever? Are you having any problems breathing? Is this something that I need to send my patient to the hospital for? And so those remain sort of the main questions that we're asking, even in the middle of a pandemic. But then layering on top of that, we also have to think about, well, who were you exposed to and who will you expose? And so what do we need to put in place so that we not just curb transmission of normal respiratory viruses, but also taking into consideration that we're still dealing with COVID, and that remains a significant health threat to most of our communities.
Is a poorer state like Mississippi and its people more vulnerable given the challenges in healthcare access here?
I think this is something that as physicians and also public health experts have been aware of for a number of years, that people who don't have access to healthcare and to resources related to health and healthcare, that the rate at which those folks get infected with viruses and also the rate at which they develop serious outcomes from those infections are higher than in communities where there's more access to healthcare and resources are better. And some of that is related to the fact that when there's poor access to healthcare, those communities tend to have higher rates of underlying medical conditions, things like diabetes and heart disease that go undiagnosed or untreated. And all of these then become risks to developing more severe illnesses when you do get a virus. So flu is much more a threat to someone with these medical conditions that are untreated or undiagnosed than to someone who doesn't have those conditions or who has very well controlled disease. And so I do think that in communities where there are not as much resources and where access to healthcare is poor, that the threat from COVID and for other viruses is greater.
All right, Dr. Branche, thank you for your information and for joining us.
Thank you.
Big thanks to House Minority Leader Robert Johnson III and Dr. Angela Branche for joining us this week. We'll be back next weekend with more of the political and current affairs coverage that you demand. I'm Byron Brown. From all of us here at 12 News, make it a great weekend.